So great. I'm glad everyone could join us tonight, and I'm particularly excited about this series this evening that we're going to have. We have Dr. Ramona Danielson with us tonight, who is from NDSU at the Public Health um, Division or Department at NDSU. And she is such a wealth of knowledge. I've been on several committees with Ramona, and I just can't thank you enough for doing this tonight, Ramona. So um, without further ado, I'm just going to let you have at it, and we'll go ahead and get started.
Wonderful. I really appreciated the invitation from Deneen. I've had the opportunity to share about the areas of research that I'm passionate about with lots of different audiences. And this is a new audience for me again, and kind of a different frame. And so hopefully we'll be able to accomplish everything that we're setting out to do today. The topic is understanding stress regulation and healing in families of children with special health care needs. And Deneen and I, and others who know me, know that I have a specific focus in adverse childhood experiences and trauma-informed approaches and healing. And so that is going to be interwoven into our topic today. So I am in public health. Public health is contagious, spread the word. And one of the things I really love about public health is that it's very interdisciplinary, and that the focus is on everyone achieving their best possible quality of life. So the background that I bring from social sciences and human development fits right in. I teach about maternal and child health. I also teach research and evaluation. And this semester I'm doing applied community health, which is great. And I am raising my two boys in Fargo with my husband, and I love taking photos, and I love sharing kindness. We're going to be talking about adverse childhood experiences and neurodevelopment, how chronic stress can show up in everyday life, trauma-informed approaches and protective factors, secondary stress and preventing our own burnout as caregivers, and healing hope and brain plasticity. And Brittany, since you aren't reading the screen, it says, if you choose not to find joy in the snow, you will have less joy in your life, but still the same amount of snow. So for those of you who are on your computer or have a smartphone nearby, I'd like you to pull up a web browser and go to a website called menti.com. And this is an opportunity for me to get a little bit of real-time feedback from everyone. So menti.com. And I'm going to be asking just a kind of a reflection on the state of the world, the fact that it's a Thursday night, everyone's had a long day already. What kind of things help you manage stress? And when you get to menti.com, you are going to enter the code 42256900. And are you able to see the Menti screen right now?
Yes.
Excellent. Okay. So we're going to create a word cloud. While we're doing that, I can fix a typo, because why not do that in real time? Neen, are you photography? I love your photos that you post.
Thank
Being
you.
alone. Sorry, was that you, Deneen?
Yeah, it was.
Yeah, I was just telling my husband about what an incredible view you have where you're at, and I've got a lot of more things in the way of my horizon these days. Long walks, reading, driving, sleep, listening to podcasts. That came up a couple times. Optimism. I really lean into optimism as well. Counseling. So we've got some really good self-care strategies in here. Movies. I love movies. I'm one that really enjoys seeing them in the theater with fresh popcorn. Screaming. Yes, can see that. Maybe some warm tea afterwards to soothe your throat. All right. Our next question. Oh, let's see. What else popped in here? Hard to see. Coloring. Nice. Yep, that's a really nice regulating activity. Absolutely. I am wondering what you see as the biggest challenges facing families of children and youth with special health care needs in North Dakota. And this can be a short response. So a couple of sentences, and it'll just pop up your response here. So I want to see what's on your mind as the biggest challenges for our families with children and youth with special health care needs right now. Got some responses coming in. I think some of you are still typing. Some of our responses: adequate services, family support, financial burdens, accessing services, mental and behavioral health, and the challenge that's posed when there's so many big new concerns that our typical challenges get forgotten. That's one that I find very challenging, is the balance of the day-to-day stresses and responsibilities with the big picture stresses and responsibilities. And if you're still typing, please finish your response. I will be able to see that still. And my last question is, how would you rate your current knowledge of the research about ACEs? And you can choose one response. I know nothing or very little about ACEs. ACEs standing for Adverse Childhood Experiences. I'm somewhat knowledgeable about ACEs. I'm very knowledgeable about ACEs. Okay, so we have the full spectrum, from someone who's very knowledgeable about ACEs to someone who is very new to this material, doesn't know anything or very little about it yet, and then several who are somewhat knowledgeable, kind of there in the middle. So thank you, and you can keep Menti open. We will come back to one more slide towards the end. Managing stress. Is anyone else going through life like, yeah, I just got to get past this last difficult week, and then it's smooth sailing from there, but like every week? Definitely one. So the frame, is everybody able to see my screen again?
Yes.
Thank you. So the frame that I want to talk about is how families of children with neurodivergence and with physical health needs, we all share a common context. And I say we because both of my boys do have autism and anxiety, other comorbid or co-occurring conditions. So, often neurodevelopmental differences, physical disability, medical complexity, chronic pain and illness, frequent care routines, appointments, and stress navigating the systems that we need to be a part of. That chronic stress on the family system, those high caregiving demands, can create this risk of overwhelm. And I hopefully am not the only one, but definitely can create a state of nervous system dysregulation, whatever the reasons are that bring us there. So there's extreme caregiving demands, oftentimes few breaks, little systemic support. Our own nervous systems as caregivers may have moved into survival, and child behaviors themselves will escalate under stress. And so I'm going to be talking about adverse childhood experiences. And I'm not saying that the healthcare needs themselves are caused by the trauma, but chronic stress, repeatedly feeling overwhelmed, unsafe interactions, unmet needs, emotional dysregulation in the environment, these things can produce trauma responses layered on top of whatever their special healthcare needs profile is. And that stress can change how their brain functions. So some of our brains are wired differently from the start. Some are shaped by stress and trauma. Many families are living at the intersection of both of those things. And chronic stress changes how the brain functions. In particular, regarding autism and other forms of neurodivergence, these are neurodevelopmental, not caused by trauma, but that stress changes how the brain functions, as I mentioned. ND families, that's easier, neurodivergent families are often exposed to much more stress, and that can create trauma responses layered on top of that neurodivergence. And many parents are, in fact, discovering their own neurodivergence while parenting a neurodivergent child. I'm in a lot of spaces about autism and ADHD right now, in Facebook primarily, and a lot of the comments are about, maybe when my child was diagnosed, the provider should have mentioned something about how genetic this is, and that maybe I also should have been tested. And that is something, since my boys' diagnoses came 8 and 10 years ago or so, something that I don't know if that's getting any better, but my sense is that it's certainly not universal. And I do think that a fair amount of the increase in autism that may be happening among adults is because they're just coming to recognize that neurodivergence, even though they had it their whole lives. And in the case of some of us who are getting close to perimenopause or menopause, some of those differences can also exacerbate some of our neurodivergent tendencies. So if you are a neurodivergent parent, parenting a neurodivergent child, you are probably going to experience sensory overload, executive function strain, emotion regulation challenges, difficulty with co-regulating, all while being asked to be the calm nervous system for your child. And that is not a small ask. And by the way, anyone can buy a birthday cake anytime and eat it yourself. Nobody checks. So the way that I like to structure a conversation around adverse childhood experiences and toxic stress is around the 4 R's of trauma-informed approaches. The first one is to realize widespread impact of trauma and understand the potential pathways to recovery. The next one is to recognize signs and symptoms of trauma among people in our lives. The next is to respond by integrating knowledge about trauma into policies and practices. And the fourth one is to resist re-traumatization, which is to actively resist triggering trauma reactions. The word trauma often means something different to an emergency department medical provider. So we're talking about an event or a series of events or set of circumstances that is experienced by an individual that is physically or emotionally harmful or life-threatening, and that has lasting adverse effects on that individual's functioning and mental, physical, social, emotional, and or spiritual well-being. So it's a very wide category, but I will give you some examples of what we have been studying in terms of the level of population health. And the Adverse Childhood Experiences study, at its core, was trying to understand the connection between experiences in childhood and patterns that the original investigators had noticed were happening among adults. And so there's this connection across the lifespan from the experiences in childhood all the way to the leading causes of death in adulthood. The way that they're often categorized, primarily in surveillance systems like the behavioral risk factor surveillance system, the pregnancy risk assessment monitoring system, is in two broad categories. One is the child abuse and neglect. The other is in what I call household dynamics. And the abuse and neglect are emotional, physical, and sexual abuse, emotional and physical neglect. And the challenges in the household, you can think of these as ways of gauging sort of the amount of toxic stress in the home, the amount of disruption to important attachments for a child. And that includes substance abuse, mental illness of a caregiver, suicidal thoughts and behaviors, divorce or separation. And again, that captures sort of maybe the turmoil in the household before that separation or divorce, and also that loss of a significant caregiver in terms of being present in the same way, incarceration of a caregiver, or witnessing intimate partner violence, domestic violence. And then what often happens is these are 10 different items. 1, 2, 3, 4, 5. So the mental illness and suicidal thoughts and behavior are generally combined into one. And so what you'll see is often a score, and it ranges from 0 to 10. And when a person is asked these questions, they say, no, none of these things happened to me, they have an A score of 0. And if they say, this one, and this one, they have an A score of 3. And so it's kind of a blunt instrument that way. It's not looking at sort of how long it was, what age it happened. And, people study those things very in depth. What is the significance of physical abuse, among males at this particular age, and sexual abuse among females at this particular age. So those things still matter. But what the ACE score is capturing is what we essentially call a dose of toxic stress. There are other adversities, bullying, community violence, natural disasters, refugee and wartime experiences, witnessing and experiencing violent acts on the streets of your community. And those aren't necessarily captured in the ACE score, but what we find is that they often co-occur. And so what we're essentially capturing is this accumulation. And it can be helpful. I think sometimes people think, well, that's not really happening in North Dakota. Many of us know that is not the case. These things are all happening in North Dakota as well, as every other state. And these are two different surveys. The first one that gives data for all North Dakota adults is coming from the BRFISC, Behavior Risk Factor System data, and the column on the right is from women who had a recent live birth, and that's the Pregnancy Risk Assessment Monitoring Survey. And so that the all North Dakota adults are including women and men of all different ages. And the PRAM survey on the right is focusing in on women who are, somewhere in that 15 to 45 age range. And the questionnaires can be somewhat different. North Dakota has, I think, added emotional and physical neglect, but in the data the aggregated data that I was looking at, it wasn't asked in every year, and so we didn't include that in the analysis we had. You can see the prevalence kind of shifts among individual ACEs. I can't say for sure that emotional and physical abuse have gone down because those are lower among women with recent live births. You just kind of have to remember they're different populations. But what you can look at the bottom is the ACE scores, and that 17% or so for the general population is a very sort of common threshold across the nation, and even from kind of the individual ACE study. And the reason that we talk about 4 or more ACEs is because that is the point at which that dose response will result in those more negative impacts across the life course. There is one survey that asks current parents about the ACEs for their children. This is the National Survey of Children's Health. And interestingly, well, obviously, I guess I would say they don't ask them to report directly about abuse and neglect. So they get at the household dynamics, and then they also get at community dynamics. And then they've included one on financial hardship, that it's hard to cover basics like food and housing. And so among all children 0 to 17, you see that there are these individual prevalences of divorce and separation, exposure to substance abuse, mental illness, incarceration, domestic violence, all of those things. And then the way they're capturing the community dynamics, they're not as high of prevalence, but they're there. And then you have, the percent where the parents said, yes, we have found it hard to cover the basics. But one thing I want to point out is that overall, the exposure to ACEs does accumulate with age. So if you think, oh, well, children have fewer ACEs, well, actually, as they're getting older, the proportion of children who have at least 2 of those ACEs is growing. And so you go from about that set of bars on the far right. Gray is that overall 20% that you saw in the last slide who have 2 or more ACEs. And you go from children ages 0 to 5 having like 15% of those children having 2 or more ACEs, up to 27% by the time they're 12 or 17. It does point to a window of opportunity to prevent the accumulation of ACEs. And so I've been involved with programs like the Maternal, Infant, and Early Childhood Home Visiting Project, which provides services from sometimes a nurse, sometimes a paraprofessional who come into the home of a family with young children, and they're providing skill development. They're providing, that emotional support. They're also helping connect them to community resources. And so it's really an intergenerational program where they're focused on you can be making changes for the parents, and that in turn will change the trajectory for the children. So looking at that accumulation over time is one of those things that helps you know that prevention is possible and also really important. As I mentioned briefly, that many of the leading causes of death are associated with experiencing a higher number of ACEs. And so among people with higher ACEs, we see a relationship to chronic health conditions, heart disease, stroke, asthma, COPD, cancer, diabetes, obesity. We see mental health conditions and substance use disorders at a higher prevalence among people with the higher ACEs, 4 or more, especially depression, substance use disorder. We see health risk behaviors related to risky sexual behavior, smoking, excessive alcohol use. And we see what's categorized here as social outcomes. And so having higher ACEs is translating to, in adulthood, being more likely to lack insurance, health insurance, being more likely to be unemployed, being not advancing as far in one's education. This is one way to visualize what that looks like. So with the 0 ACE score up at the top, even for people with the 0 ACE score, you're still going to see severe obesity. You're going to see diabetes and depression and STDs and heart disease and cancer. And and high rates of missing work due to physical or mental health issues. But the circles are pretty small. That represents that among those people with ACEs, that's not happening all that much. When you get to the ACE score of 4, you see the circles are much bigger, and that's representing that among people with ACE scores of 4 or more, many of these things are happening more often, and they're happening in tandem often. And another way to visualize it is the actual dose response. And so you can see what each of these little graphs represents is on the left is an ACE score of 0, and then a 1 and a 2 and a 3 and a 4, and as it goes up. And so you see that the rate of people with anxiety goes up. This is kind of general data. This isn't North Dakota specific data, but about 2% of people with an ACE score of 0 have anxiety, and 15% of people with an ACE score of 4 or more have anxiety. About 10% of people with an ACE score of 0 are smoking, and it's 29% among people with 4 or more. And you see that relationship with many, many of these issues. And here in North Dakota, just an example from that BRFIS data, higher ACEs are associated with lower education and income achievement. There are also racial differences. And so among college graduates in North Dakota, 11% have an ACE score of 4 or more. And among those who do not have a high school degree or are high school graduates only, it's 26 and 20%. So, approximately double. Much higher than the baseline of among those with lower annual incomes. And we see higher rates in our Indigenous and Hispanic populations in North Dakota, for example. And that can reflect a lot of systemic issues, as well as the effects of historical trauma and, continuing trauma in these communities. And you can see the higher likelihood of chronic disease and health burdens. And I just want to draw attention to the 3 on the right: frequent poor mental health and frequent poor physical health. That means that someone with a score of 4 or more compared to someone with a score of 0 is 3.7 times more likely. I believe the definition is to say that their health is poor on at least 15 days of an average month, that their mental health is poor. Frequently, that's almost 6 times more likely, and almost 7 times more likely to have a depressive disorder. I want to emphasize that this is essentially a public health surveillance process, and ACEs are describing the population level risk patterns, not the individual trajectories. And so it's important to know that ACEs are not destiny. But we can see those patterns play out. And with my mom's permission in the past, and she is joining us today as well, my ACEs journey began with my mother when she had a diagnosis of stage 3 aggressive breast cancer in her mid-50s. And she was frustrated to have this diagnosis and feel like she had breastfed her children. She was physically active and of a healthy weight, and there was no history of breast cancer in the family. And as she was doing her research out there, she learned that the highest risk factor that she had, that no one seemed to know about or talk about yet, was her ACE score. And her ACE score is 9 out of 10. And here you see the beautiful 1-year-old Linda on the left in Los Angeles. And then the family moved to a remote mountainside in Alaska as homesteaders, in part to, I think, isolate Linda from any support systems. So an individual who records 4 or more ACEs is more at risk for the following long-term health complications, so nearly double the risk for any cancer. But speaking to the fact that these issues often co-occur, depression, alcohol use disorder, COPD. These are also issues that my mom has experienced. And then in later adulthood, she has come to identify characteristics of autism and, self-diagnosed, which is, it's hard to get a diagnosis. It's hard to go through that process, but a lot of convincing information about this. And considering that her grandsons are also autistic, and there's that family relation, and kind of makes me wonder where my neurodivergence sits in the middle there. But wondering what being autistic maybe contributed to the really awful abuse that she experienced from her mother. We know in the 1950s, there wasn't any support around, understanding what autism would have looked like, or why, her second child may have been different from the others. But also, I think she basically also had a psychotic break during birth. So kind of a lot of complicating factors there. So I want to explain briefly how toxic stress gets under the skin. As adults, and my ACE score is in the 4+ category, but thankfully not anywhere near my mother's. But as adults, we will tend to respond to stress more strongly, if somebody else might perceive it to be an overreaction. It can take longer to return to a normal level of stress. Our bodies can stay stressed longer. We can be extremely exhausted after responding to stress. And you can think of it essentially like revving a car engine for days or weeks at a time. So you basically bathed in cortisol, and your body has become adapted to this. So what is happening, we understand more now than when the study actually was first conducted in the mid-1990s, as initially came out. They didn't have a lot of understanding about the neuroscience or even the physiology that came along with it. But we're understanding that there are effects on the hippocampus, the cerebellum, corpus callosum, prefrontal cortex, and inflammation from cortisol. This can interfere then as a child is developing, and as that person is experiencing adulthood as well, with learning, memory, coordination, emotion processing, and threat perception. And heightened inflammation can also be interfering with the immune system. We can see that childhood adversity can impact executive functioning. It's not necessarily happening evenly. So somebody can be shining in some areas and struggling in others. And so this begins in childhood. You can see it then in adults as well. You may see, for example, that all these areas of executive functioning, or some combination of them, can be impacted. And so it may look like we are more hypervigilant, not able to ignore stimuli that might bother others, interpreting something as threatening that others might perceive as neutral, showing more inhibition or less inhibition out of proportion maybe to a situation from others' perspectives. Maybe some of the healthy coping strategies others might choose in a situation aren't as readily available. And how quickly and intensely do we experience a negative emotional reaction? And moreover, how quickly can we get back to regulation and baseline? And it's important to know that when children have been growing up in an environment where they were exposed to toxic stress, that they were adapting to survive, that these were, when people first started talking about it, they talk about maladaptive behavior. And that isn't the appropriate way to think about it, because it was absolutely adaptive for the environment that they were in. But when you take a person who is, become hypervigilant to survive, and you put them in a school environment where the expectations are based on neurotypical and non-traumatized brains, then there's a disconnect, and it can be difficult for them to function and to thrive. There are some situations, though, where people who are hypervigilant can excel. Those are really good skills. For example, if you're going to be a firefighter or in, emergency response of some kind. And on the converse side, when somebody hasn't experienced any stress in their life at all, they can find it difficult to function when they're exposed to stress. And so sometimes people, even if they're reacting, intensely, sometimes they can, be the ones that are really, really helpful in a particular situation where that kind of response is required. I want to briefly mention re-traumatization because that's kind of one that people have a hard time getting their heads around. That can happen at the system level, where policies, procedures, just the way things are done can be re-traumatizing for people. Having to continually retell your story or your child's story, being treated as a number, being seen as just a label, not feeling or being given any choice in service or treatment. And at the relationship level, it's often about power or control, where you don't feel like you're being seen or heard, lack of transparency, having things done for you rather than with you, and generally coercive or oppressive approaches. And so in a helping environment, for example, you can call this sanctuary trauma. And somebody would say, we're here to help. We work really hard. How can helping environments be triggering for or even re-traumatize people we work with? And so if you think of that environment, you can imagine the sights and the sounds, sense of lack of power, feeling invalidated, medical procedures, communication barriers. And I can say, from experience, helping my mother through her cancer treatment, that sanctuary trauma was definitely an issue, and just even sort of walking in the door. And so, even the oncologist in particular was pretty awful, actually, in terms of being re-traumatizing. But even just how the staff who bring you in, and check you in, having trauma-informed approaches can really make a difference there. I'll talk a little bit more about that. So I'm going to lay out some unfortunate realities, but it's really important to this conversation. And it's that children and youth with special healthcare needs are at higher risk of abuse than other children. And it's actually about 3 times more likely to be abused or neglected. They are more likely to be seriously injured. And the risk varies based on family and parental risk factors, the factors related to the child, the specifics of their healthcare needs. But it's really, I think, important to provide some context to what parents of children and youth with special healthcare needs are experiencing. So it's not to say that this statistic doesn't matter, but it's to say that the vast majority of these parents are probably not just being cruel. The stress the families are experiencing is extreme. The systems are often failing our families. There's often growing isolation. Often the regulation resources are scarce, and that high stress plus no support puts everyone at risk. And in fact, many parents themselves have experienced ACEs. So many parents are carrying their own ACE histories into being a caregiver, and then that interacts with today's stress. And so that can make regulation harder under pressure. Chronic caregiving stress can reactivate old survival wiring. Without support, cycles of stress can escalate. With support, those cycles can be softened, even when life stays hard. Objectively, maybe the factors of life aren't getting easier, but with support, we can see tons of improvement. And so support and awareness can really interrupt that cycle. And even partial reduction of ACE exposure matters. And the choices that we're making today can help shape our own child's ACE profile, which is part of my why I do what I do, is to help continue to disrupt that cycle for my own children. So the expectation is that when little people are overwhelmed by big emotions, it's our job to share our calm, not join their chaos. That's great. But if co-regulation feels impossible some days, it's not because you're failing, it's because two overwhelmed nervous systems are trying to stabilize each other. And that is asking a lot. And I would talk about, as my kids have grown, that it's like I have to be on 100%, and who is perfect 100% of the time. And then, it's very distressing when you react in ways that, you don't show your best, your best possible parenting. For a lot of parents, the child's behaviors can actually start to feel abusive, and the parents can themselves get triggered. I've experienced the screaming, the hitting, the biting, destruction of property, the emotional volatility, and swearing and insults. And this can create parental trauma responses in and of themselves: hypervigilance, anger, shutdown, despair, intrusive thoughts. And without support, that risk grows, and not because they're bad, but because they're being overwhelmed, really, to their limits. And I laugh or chuckle at the phrase "calm down" has 100% failure rate, because when my son was younger, I remember trying to say "calm down," calm, just red, screaming. Yeah, not a successful phrase. So one of the things that we can be doing is replacing this concept of self-care with nervous system care. So caring for your nervous system is really caring for your child's nervous system. How do we accomplish that? Looking for brief moments of calm, predictable routines, safe connection, asking for help, taking real breaks when possible. And I like the box on the right here, that medicine isn't always found in bottles and tablets. Exercising is medicine. Fasting can be medicine. Nature, laughter, vegetables, sleep, sunlight, gratitude and love, friends, and meditation can all be medicine. This is, just a reminder that we have kind of chemical processes happening in our brain. I don't have a scientific resource for this, but it's the idea that we can trigger our dopamine response when we complete a task and celebrate little wins, and oxytocin through, playing with a pet or hugging family, our mood stabilizer, serotonin, through a walk in nature, through some sunlight, some meditation, and endorphins through laughter, dark chocolate, exercising. So helpful practices can be support from family and friends, help with baby and other children, increased self-care, getting adequate sleep, eating a healthy diet, time with supportive friends, spouse, partner, spiritual practice, and support. And I recently was on a webinar where they shared some practical regulation strategies. And we see some of these sometimes in apps, but there is some science behind when you do the slow breathing. So this is a 4-4-8 breath. That's activating the parasympathetic system. So you inhale for 4, hold for 4, and then this really long exhale. They find you can sort of hack your brain's anxiety sometimes through an orienting process. Look around and name 5 neutral items. Sort of naming your thoughts, the mindfulness process. If if where your brain is going is really not fact-based and it's maybe a lot of anxiety, you can name that, okay, I'm having a thought that, and also looking at, what do your feelings, how do they connect to your values? So, what does this anxiety, for example, show you that you care about? Another way to kind of re-shift the brain is about tell me about a favorite memory, and have and you can ask somebody to do that or do it for yourself, where you think through the sensations, the images, the feelings, thoughts you have about it. And then engage all senses. What are 5 things you see, 4 things you can touch, 3 things you can hear, 2 things you can smell, 1 good thing about yourself for your day. These are not, big cures, but they're little things that you can maybe keep handy that can help with self-regulating. One of the things that's important to remember is it's not about perfection. We are doing the hardest work of our lives while carrying our own histories of stress and trauma. So our choices today matter. They shape the emotional environment our child is growing in. They can lower the stress load that our child's brain is carrying. Prevention, when we talk about prevention, we can keep ACEs from happening altogether, but we can stop the accumulation of ACEs. A 2 is better than a 4 is better than a 6. And we can support the resilience among people with ACEs, and specifically resilience is about the protective factors. And I believe I have some slides about that coming up here. But even small shifts can really help change the trajectory of a developing brain. So 3 principles to reduce long-term effects of ACEs and toxic stress. We can be looking at strengthening life skills, building responsive relationships, and reducing sources of damaging stress. One of the biggest things that we can think about is how do we buffer stress for children and for ourselves, because there are some types of stress that are positive, can help build our normal and healthy, and kind of help build our stress muscle. And then there's the toxic stress. And there are times where, with enough buffering, toxic stress, the tolerable stress, I should say, if it's buffered, it can function positively. If it's unbuffered, it can move into that toxic stress area. And so that buffering is really important. Talking about the importance of caring and competent adult relationships. Protective factors can stack to create positive outcomes. And this is the Center on the Developing Child at Harvard. They talk about the supportive adult-child relationships, opportunities to strengthen adaptive and self-regulatory skills, and then positive experiences, such as those found in sources of faith, hope, and cultural traditions. And one way that you can think about it is like a seesaw or teeter-totter. And when the positive experiences outweigh the negative experiences, the seesaw can tip towards those positive outcomes. And when we say that healing is possible, over time, resilience can actually shift sort of the tipping point, the fulcrum, and make it actually easier for the seesaw to tip toward positive outcomes. There are there's some research around specific resilience factors, like feeling social and emotional support and hope, having 2 or more people who help. That would specifically be concrete help when needed. Community reciprocity in watching out for children, and social bridging, people reaching outside their social circle to get help for their family and friends. One of the challenges about focusing too much on the concept of resilience is that a lot of people almost end up victim blaming that, why aren't you more resilient? Why aren't you more socially, why don't you have more friends? Why aren't you more hopeful? And those areas are actually impacted developmentally by the stress, by the trauma. And so that's where the trauma-informed approaches come in, where we create these supportive environments around people, understanding that we're trying to avoid, re-triggering and re-traumatizing people, and we're trying to create these environments of support. But there's research, this is coming out of Washington State on their behavioral risk factor surveillance. And it's kind of complicated to explain, but essentially it's saying with 0 ACEs and low support and hope, you have about, was it 17% who had poor mental health for more than half of the last month. And as you get to the 4 or more ACEs, having low support and hope, you have, closer to 40% of people with poor mental health for more than half the last month. But when you add the high support and hope, even when you have high ACEs, that mental health improves dramatically. And so, how do we create systems that support that kind of high support and hope? For our families with children and youth with special healthcare needs, we experience months-long wait lists, insurance denials, so much paperwork, repeated storytelling of diagnoses and related traumas, lack of trained providers, little coordination often between schools and healthcare and community services, and often minimal trained respite. So no matter what you say, and I knew it was me because I recognized my voice and I was wearing my underwear, today is going to be a good day. When the systems fail us, that's not a personal failure, that's a systems failure. What we need, are access services without impossible wait lists, stable providers who know our family, that continuity. We need coordination, fewer hoops, fewer silos. We need real breaks for caregivers from people with training. We need flexibility and accommodation. We need to be recognized as the experts on our children, and we need early support before a crisis, not after. When a flower doesn't bloom, you fix the environment it grows in, not the flower. From a trauma-informed perspective, we're looking to create senses of safety, providing individual options in their treatment, noticing capabilities and really empowering our families, making decisions together, and showing trustworthiness, providing really clear and consistent information. So we're looking to see that infused throughout all of our systems. So our trauma-informed systems are proactive, they're family-centered, they're culturally responsive, strengths-based, coordinated, easy to navigate, grounded in respect. We are carrying more than most systems are built to hold. Checking on my time here. I think I'm getting pretty close. What slide am I on?
It's okay.
Okay, very close. Families raising children with special needs need more support, not more judgment. Our brains remain plastic across the lifespan, so healing is possible for children and parents. Healing is not about perfection. And what we can do, we can have self-compassion, build protective factors, practice co-regulation tools, prioritize our nervous system care, foster hope and plasticity. Brains do remain plastic across the lifespan. Children, parents, families can heal. Small changes can shift whole trajectories. No one has to do this alone. So these are my little guys growing up. That even the picture on the right is a little a year or two old, and so they're not so little anymore. I'm happy to take questions here. I do have one more Menti slide, maybe for some reflection, and then we can do some questions. But I'm also very happy if anybody wants to reach out to me at ramona.danielson@ndsu.edu. So if we can go back to menti.com, and I would love to just kind of have you reflect on a key takeaway for you from this presentation, an aha moment, something you'll share with others. And then I'm also happy to stay for some questions.
Great. I have a question for you. First of all, thank you so much for addressing all of the, I'm trying to figure out there we go. Which camera am I on? I just want to say thank you so much for addressing the ACE. I'll be on some calls with different organizations and everyone addresses it. And then some people say it was just, it's not really, they kind of discount it like it's not that important. But I do think it's important because I feel like when people see that, they kind of go, oh, okay. And like, I mean, we could read The Body Keeps the Score. We could talk about like all the books that like resonate with this, right? Like, and then like in real time that happening to people that you know. But like the most condescending thing that I got when I was talking to someone about it, they were like, well, what's your resilience score? And I was like, well, I was like, I understand like what you're saying. You're like, I don't want to hear it. Like, what's your, like, how are you going to solve it? Right. And I'm like, well, I'm like, well, I think first we need to, as like a whole picture, see how raising does impact people, right? Like life things impact people. So I'm not saying like we should, figure it out. I'm not saying that. I'm saying that like we need to pause and see how much more somebody could take, right? Or these kids can handle, or whatever the case is, right? So can I just tell you, like, thank you so much for going over that and talking about it more. I think it needs to be talked a lot. I wish that every provider, every doctor's office had it. I think that would give them such insight. Like, and I know that it's not going to be something like that, but like, I really, maybe one day it'll be something like that, right? But I appreciate this. Like, it was awesome. Thank you.
Thank you. Thank you for your comments. I'm sorry you've had those experiences where it's minimized. I think a lot of times people don't know what to do about it. And I think when people first started talking about ACEs, they talk about how it had these negative repercussions and then just sort of leave it there. And so talking about the importance of those protective factors. And for me, really the importance of not victim blaming or shaming to some extent. Like, what if your resilience score was low? Then they're going to, and it's like, well, maybe I didn't have a lot of protective factors growing up, but that doesn't mean I'm a lost cause now. Like, there's a lot we can put in place around people to really improve their well-being. And we have that, I think. Again, something I love about public health, like that's our goal, to make sure everybody has their opportunity to achieve their best health and well-being. So I think there's a lot of hope there. That's one of the some of the takeaways: hope, knowing you're not alone, and just some reflections, taking a closer look at your own ACEs. Somebody who's saying mine's probably pretty high, or one who's saying mine's not high, but helps you understand more, in this case, about maybe their mother. I think a lot of times, some of those little tidbits, I think they just really encapsulate it so much. Don't judge my story by the chapter you walked in on. People shouting at us to do self-care without providing support. What you really need is community care, helping make sense of behaviors. And I'm struggling a little bit with the frame in terms of it's not assuming that everybody who has children with special healthcare needs has a high ACE score, but many of us do. And what's in common is that really, really high stress. And I think there's a lot of commonalities in understanding what that does.
Is there a site where if somebody on here this call was curious about what their own ACE score is, that they could do that?
Yeah. Let's see if this one does it. A couple of different places. So I'll pop this in the chat, and with all the things on my screen right now, I just have to find where that chat went. Here we go. And essentially what it is it walks you through questions, kind of capturing those 10, and there's so much nuance to that. And it's really not meant to be diagnostic. If a care provider is going to be looking at trauma, there's other screening tools that are validated specifically for looking at trauma. But it kind of gives you a sense, right? Yes, Kara, I'm happy to share the slides, and Deneen said she'd share that with the recording as well. Hi, Mo. I didn't see you pop on. Other questions or comments?
I'm gonna shut the recording off in case somebody wants to ask some personal questions. I don't know, but I'm just gonna do that. So thank you, Ramona. My God, did I learn more tonight than, and I thought I knew
Awesome.
quite a bit about ACEs, but I did learn a lot tonight. So yes, and I will be sending out the slides with so if anybody that registered will get these tomorrow and then plus the recording.